what increases your risk for mortality? And I know in men, it's often like loneliness and a sense of social isolation. And what's so great about running, especially in Canada with the running room, right? You got like people meeting to run every Sunday morning at that store. Like for a lot of runners, it's who they are. It's their social network. I would never take that away from someone. Like,
Yeah.
you gotta keep people doing the things that they love. That's huge. Yeah. There's less of a social network and trampolining. That's the problem. That's what I miss about running. Oh, right now, are we recording?
Yeah, we record from the start. Usually what I do, I don't have a formal start. I just start talking and then I go back in the edit and I find an appropriate place. Otherwise it feels a little bit, a bit too formal.
Oh, okay.
All right, let's start over. Start over.
I talked before.
So
That's
could
funny.
you tell us a little bit about your clinical background, what you do and what your interests are?
Yeah. So my clinical background, I was a chiropractor. 18 years ago is when I graduated. And before that, I did a master's in exercise and spine biomechanics. I was a strength and conditioning coach. And then I became a physio in 2010. So like 11 years ago. Never really changed my practice, but I treat people with pain, all types of people, elite athletes to persistent pain, grandfathers. The principles are the same to me. Hopefully they want to be active. That usually helps me. That's how I like to treat, is activity and movement and all that stuff. Now I still see patients, but I primarily travel in theory to teach my course for the past 6 years. So it's like more education for therapists and some education for patients. And then I have an active blog and I do some research, but mediocre stuff.
And are you still calling the course Reconciling Biomechanics with Pain Science? Is that your sort of theme? So what does that mean? What are you talking about?
It just means pain is multifactorial. It's influenced by a number of factors, more than just mechanical aspects. And I would say for too many years, we've focused on the wrong mechanical aspects and the idea to the detriment of people. And I believe in like simplifying the mechanical aspects so that you can start to address other areas that influence pain as well. Like don't get caught up on like your foot posture and your knee caving in 1 centimeter and your anterior pelvic tilt. That's like the wrong road to go down. We shouldn't be focusing on those things. That's the thrust of the course. Yeah.
What should we be focusing on? Do you think? Where are we missing the mark?
I mean, so if I have pain or someone I'm working with has pain, let's say, they're a runner and their knee hurts, we would look at like really general, like simple things like, are you just doing too much than what you're ready for right now? It doesn't mean there's anything wrong with how they run or even how much they're running, but there could be something going on in their life where they just can't tolerate the running stressors at that point in time. So the question is, do they have to back off and do a little bit less for a while, or do they have to add something else in their life? Meaning that could be recovery, that could be looking at their sleep, that could be their diet, where you ask big questions like, how can you be healthier? That sort of idea. It doesn't mean like they're running too much, like in general. Like, doesn't mean if they're running 50 kilometers per week, they might have to back off to 30 for a while. But in 6 months from now and for years later, they could be running 50, 60, 70. There's not something about their body that can never run 50 to 80 kilometers. There's just something about their situation at the time. And we don't always know that means it's too much for them right now. So that it's things like that you'd focus on.
Why would their situation influence, let's say if we sort of zoom in on the knee, so everyone is having knee pain, why would their situation influence that pain?
Yeah, we don't know, but thanks for making me look dumb. We really don't know. It's that multifactorial. It's like saying, and I apologize for everyone who's listening because like, what is this guy talking about? But it's like having a piece of cake and trying to identify what your favorite ingredient in that cake was. Is it the eggs or yeast? I don't know if there's yeast in cake, flour. You know what I mean? Like, it's not complicated. So you kind of have to Yeah, you're still gonna, like, you'll look at the simple mechanical things like backing off, but you'll also do things to build that person back up. Like my general heuristic is, calm shit down, build shit back up. That's it. So anything you can do that can help with your desensitization, that's worth doing. That's where you get weird treatments that don't always make sense. It could be like massage or manual therapy, and someone will say, "Oh, I'm breaking up fascial adhesions or something." You're not, but it certainly can be calming down your nervous system so you have less pain. And then you start running again, and slowly, like building up your volume, and that builds you up so you can handle the running demands again. Or someone else says, I picked up some cross training. They started doing more elliptical, or they started strength training, and that helped for some reason, or Tai Chi. I'm like, good. So adding something helps you tolerate the demands of running. It's like, it's tough because I'm not being definitive here, but it's good in a way, because if you've been struggling with pain, it means that there's still hope, because there's lots of different things that can help you.
Well, I think potentially there I asked too big a question, right? Because when you said, we don't know, it's like, well, I've heard you talk, like I've followed your work for a long time, and I've heard you talk about all the reasons why. And I think what you really mean is there's lots of, it's very complicated, and
Yeah.
some ideas, but we don't know the full story really on why other things influence pain.
Yeah. So like a good example, I'm having this debate on Twitter. It's a debate I've had forever, is if you have knee pain or pretty much pain anywhere, if you do some sort of exercise somewhere else at a distance from that, everyone says you got to strengthen the glutes if you have knee pain. Sure, pragmatically, that will help people. But it's also interesting, if you strengthen or do strength exercises for the hip adductors, so your groin or your hip flexors, that will help with knee pain, right? And so so it just seems like doing something else somewhere else. And you could also do the foot muscles. Like if you just strengthen your calf, those things will help. And then it turns out it may not be because you got stronger. Like we're doing strength exercises, so we just think, oh, you need to be stronger in order to run. Well, that's not really proven either. It's just that you're doing some sort of exercise. So that exercise helps pragmatically. So we have like research that says these things help, but we don't have research that tells us exactly why they help. So we shouldn't confuse like ourselves thinking, oh, you have to get stronger. What we can say is, oh, you probably should do exercises somewhere else. There's a subtlety there.
Okay, so as a physio, I've certainly given glute exercises to people with knee pain.
Me too.
Right?
Yeah.
So, and they have got better. And potentially in my head, I tell a story, their glutes were weak, their knee was going in, their glutes are now strong, their knee no longer goes in, their knee doesn't hurt. And I think what you're saying is that if you sort of go back to the start of that story, and instead of strengthening the glutes, you strengthen the hip flexors, it would sort of derail that story. But what you're saying is there's research that shows strengthening the hip flexors, so they pull their knee upwards, those muscles, that would help. Would it be equally as well?
Yeah.
And now our story doesn't make sense anymore. So there's got to be some other explanation for how these are helping with pain. Is that what you're... That's
it exactly. That's it exactly. Or what often happens is like people think it's strength, and why don't you could do like endurance exercises, and then that'll be just as helpful. Right. So that's fascinating to me, because it just means that there's so many other options. Or if the principle is just train some other area, you can choose exercises based on some other goal, not thinking, oh no, I have to get the glute med stronger. You can choose an exercise because you enjoy it more, or for performance. Like I would actually, if you're a runner, I would advocate doing more hip flexor exercises for the performance related to running. Or if you're a female, because you'd be more predisposed to like bone density related injuries, I'd advocate doing some sort of exercise that's going to help your bone density. If you're a male as an athlete, you tend to like lose calf strength and tendon stiffness in your calf. So we'd say, well, let's choose exercises that are helpful for this, because it's better in the long term. Do you know what I mean? Like you get to, it's great because you get to choose an exercise for another potential benefit. And then the side effect is that it helps pain.
And the exercise biomechanically doesn't have to explain why it would help with pain. So you don't have to go with the biomechanics. It's like, we know exercise helps with pain. It doesn't necessarily matter which exercise at which part of the body? I mean, could you go far away? Could you, have someone with knee pain, a runner has knee pain, and you get them doing shoulder pressing, right? Is that going to help them? Or
I know people have said that. I had someone just do pull-ups, but we were also doing hip stuff too. I was like, because there's this general analgesic effect for exercise that just occurs everywhere. And there's a general anti-inflammatory effect for exercise. So it might be, but I also think there's psychology involved. And since pain is influenced by psychology, that might be a harder sell. It doesn't make sense. So like, you may not be tapping into all the potential things that influence pain. So I would have trouble saying do shoulder presses for knee pain. But I know people do.
It reminds me, I heard, I've forgotten his name. Is it Neil Pearson, the Canadian pain?
Yeah, the yoga guy.
Yeah, so I was watching a lecture online, and he was talking about a study where they looked at people who were thirsty, and then they gave them a drink of water, and then they rated their thirst score, and it was lower immediately after drinking the water. And he's saying, well, they're not, it hasn't even got to their stomach yet, never mind their blood.
Sure.
But they're not thirsty anymore. And I remember the phrase he used was, they've taken the action that they needed to take to address the problem. So is that potentially why you and I would both be hesitant to give a shoulder exercise for knee pain? Because we have to have, okay, my hip was weak, my knee's caving in, my hip is now, do we need that narrative? Do people with knee pain need some sort of explanation? Could that be the mechanism for why the knee pain reduces, because they've taken the action needed to address the problem?
I think it's absolutely a huge thing related to it. It's why just like when you look at surgery studies where they have a sham surgery, there's no difference between the groups. They didn't actually do surgery, and both were effective. They helped a lot of people. So there's something huge there. And then this doesn't mean the pain is just in your head. Remember the way your brain works, it's the nervous system that actually influences what happens at the level of the tissue. You can decrease sort of the sensitizing chemicals down at the knee when you feel hopeful or optimistic, or like what Neil said, or related to triathletes and runners, like Alex Hutchinson writes a lot about this. It's this, if you give someone, when you give them Gatorade when they're running, right? If they just swish it in their mouth and spit it out, so it never goes into their body, you'll see a change in the glucose in the bloodstream. So right, it's just like Neil's example. Wow. So it's done its job. Yeah, that's an even better one.
Like I knew that they got a perception of that they felt more energetic. I knew that. I didn't know that the
physiological change. There's a physiological change. It's not just a perception. It's not just perceptual. There's an actual change in the physiology when you swish Gatorade around.
Could that be
the brain is predicting?
Right, for why the knee pain no longer hurts is some sort of physiological change around the knee, but it's because you've taken the action needed to address the problem, or at least you believe you have.
I think that's the idea. I still also believe that changing tissue and mechanical stuff is helpful as well. And so because I can't be sure, that's why I would advocate work on a number of things.
Right. So you're sort of covering all your bases.
Exactly. Yeah. That's the belt and suspenders approach to rehab. You don't want your pants to fall down. Gotta have two backups here. Right.
Okay, well, if we could circle back, because my original thought for this, we'll go down a little rabbit hole here, was to talk about arthritis. I wonder if we could circle back and relate that to an example of, if we start at the beginning, a lot of runners are told to stop running because, they get an x-ray or whatever, and it says that they have knee arthritis. And I wonder if just to start right at the beginning, I mean, so that it makes sense when you're talking about some of the other mechanisms, what is arthritis? Like when someone says that to a runner, what are they actually talking about?
Yeah, so I would argue arthritis is pretty much going to occur because you were born. Let's say that it's not that influenced by the physical in your life, right? It's these. The definition of, or the criteria for knee arthritis. I don't memorize this stuff. It's obviously you have knee pain, okay, In the morning, you're stiff. There's a stiffness, but it doesn't last longer than 30 minutes. If it's really lasting 30, 60, 90 minutes, then you start thinking that it's not your classic osteoarthritis. Could be something else. There's some change in function. Hurts to go upstairs. Your range of motion can be decreased. There'll be some bony changes, so the bones will look different superficially. So that's like your classic criteria for clinical knee osteoarthritis. You don't need an x-ray. I think they've just sort of changed the diagnostic criteria. Most doctors would be like, we don't need it, but we'll get one for you. Everyone still gets it. And then on the x-ray, you'll see like more thinning of the cartilage. But again, if you're over 40, even without knee pain, you'll see like 40% of people with these osteoarthritis changes. And so just because you have those changes in the cartilage doesn't mean you have pain. I would suggest that they increase your risk for pain, but it's not destiny. It's not irrelevant. The tissue's not irrelevant, but it doesn't mean you have to have pain, and it doesn't mean you can't get better. And it also doesn't mean that you're doomed. This is the nice research. This is me being an optimist. When they follow people for like 5 to 7 years, when they have osteoarthritis changes and they have pain, most people don't get worse. I think like greater than 80% just stay the same. So it's not always about progression, at least up to 7 years. So to answer your question about like, how is it relevant to runners? This is what I mean about reframing biomechanics here. Like, instead of viewing load and running stress as a force for bad or like a negative, I would view it as a force for good. It's like running, and healthy running to me can sort of help you tolerate those little changes in your joint that might predispose you to a little bit of, to some discomfort and sensitivity. That's the other way to look at it. It's a healthy thing to do. That physical activity is something you should be doing so that you can tolerate these normal age-related changes in the knee. That's the reconceptualization in the past. I'd say it's over the last 20 years. I'm not the first to say this, that's for sure.
I think I know what a listener is going to be thinking. Is when I think of when I think of arthritis, I mean, the image that pops into my head is an x-ray. And I think that's the general perception of arthritis. And I think what you just said is a little bit different. So if we're talking about knee arthritis, I think someone listening to this is immediately going to imagine the knee x-ray. And if they know a little bit more, they might imagine like a loss in space on the knee x-ray, or maybe some extra bony growth stuff. And what you're saying is that's not knee arthritis. Knee arthritis is more of a clinical condition that involves, pain, loss of function, and that you're saying may not even require an x-ray to be diagnosed. Yeah. Is that right?
That's it. And usually, and over 50 usually, or 45 is the other criteria. But yeah, that's the thing. That would be like structural or radiographic osteoarthritis. You can have those changes, but plenty of people have those changes and don't have pain. Or you have pain and you have a tiny amount of changes, right? Or someone else has, a shit ton, huge changes on their x-ray, and they only have a little bit of pain. So there's like a poor relationship between the changes. But again, I don't want to, there are times when it is relevant. There are people, like if you're a runner in your 50s or 60s and you've tried a lot of good therapy and your knee still really hurts and you have OA changes, there are times where the surgery is excellent, and you can actually do quite well after it. So I don't want to if you've been struggling with it for years, and this is the great thing, is you can keep running after it. I would definitely consider a knee replacement. If I was in my 60s, tried everything, I couldn't really run at all. My life was, all the things I love to do was influenced. I'd be like, yeah, I'm ready to do it because I want to be more active. So there is a role. It's sometimes relevant, and that's the problem. We just don't always know when.
Would you keep running afterwards if that happened?
Totally.
And we're talking about a knee replacement here, I presume.
I absolutely would.
Why?
Because that's why I got it. To be more active. Otherwise, there's no point.
I guess the loaded question there is it not that they wore out their knee, then they replaced it, and then the surgeon's going to be mad that they go and wear that out as well.
You know, I mean, even to me, so fine, it wears out like a couple of years earlier than it would already. Who cares? So then I get to run for 10 to 15. It's about quality. You know what I mean? It's okay. Or whatever sport I'm doing. I keep changing my sports. I don't run as much anymore. It's skateboarding right now and trampoline. So it's just, there's plenty of, there are a few papers look at people who have these implants, that the replacements, and they're able to run and keep running. So we're starting to do studies now, and you'll hear tons of, if you go online and search like running with a knee replacement, I think there's like a bunch of course, Facebook pages just saying, yeah, it's awesome. I love this. Keep doing it. Like,
yeah, I did actually try and look into the research a little bit on that. It just doesn't seem like there's a lot.
There's not a lot. There's not a lot. JF Esculier, he would be a good person to talk to or look up online his work. I think he's getting more into that. He's a running injury related researcher, but in order to, I haven't talked to him about this, but he's doing a lot more knee OA stuff now. That's where the money is.
All right. Okay. So you made a website, and I watched all the videos just the other day, and you were you've called it OA Optimism. Could you explain, what the purpose of it is and why you called it OA Optimism?
Yeah, it's just a derivative of like my catchphrase of like movement optimism. So I'm like, oh, it's because people are so negative when it comes to osteoarthritis. Like, oh no, your knee caves in, you got all these postural faults, you have to stop doing everything. And I'm like, no, this is fine. It'd be weird if you didn't have OA changes. What's wrong with you? Your knee looks like it's 20 years old. Like, that's weird stuff, right? Like, you have to start doing the things that you love again. That's the whole point, right there. Like, yeah, and this is the other thing, like, when it comes to pain, and I'm not saying you're going to be pain-free if you start being active again, when you have knee OA. What exercise and activity and changing your mindset and being healthier again, what they typically do is take people from like 5 out of 10 pain, whatever that is, that's the average, to like 2.5 or 2, that's a good success. So their knee still hurts sometimes, but here's the thing, they're doing the things that they love again, right? Like, we have to normalize having some pain. Like, I'm sore today. That's because I'm active. I'm 47. That's normal. And I know people who are pain-free all the time, but then they have massive flare-ups and they're out for a few days. That's normal too. Like, we have to like normalize having these aches and pains. And it doesn't mean stop, because stopping sometimes won't help your aches and pains either, right? Keep doing the stuff you love. That's
it's like the risk of doing nothing, right? There's that, if you don't run, there is a risk to that too. If you stop running because you want to protect your knees, that's not without its risks as well.
Yeah. And again, I when we look at the research on running and protecting the knees, there doesn't seem to be even that idea. Just running doesn't seem to make them wear down. Maybe at a massively extreme amount, like in elite runners doing huge amounts of running. But for the majority of people who, just run 20 to 50K a week, that's a recreational runner. It's not doing it. It's not how the body's built, right? It's built to respond to these stressors and build up, if anything.
Yeah, I think that's the thing we often struggle with, is we think of our joints a bit like car parts, right? And the more you use them, like, you've got a certain amount of use in them, but it's not the right way to think of them, because being alive will respond to stress, so if we run on our knees, our bones will get stronger, our muscles will get stronger. I believe even our cartilage will respond in a positive way in some way.
There's a few, again, JF Esculier has some studies about, if people go for a hard run, you'll see these changes in the cartilage after that tend to be precursors to positive adaptations. And then if for any of the mice that are listening, we know that mice, when they run, get stronger, like discs and cartilage. And there's some studies in humans, where they give strength training exercises, and you'll see positive adaptations in the cartilage, and not just in kids. This isn't like when they're 13 or something. This is like adults, 40. So you still will see it. And yeah, your adaptability is limited. Like you can only adapt so much, but you'll see some changes. You're definitely not seeing more wear and tear, right? Like, so here's an example. I know we were going to talk about this, but I'll jump ahead. When people lose, so they have knee OA and they might have a BMI like over 30, which would be on the higher side, and it would be suggested that it's helpful to lose weight to help with pain. The assumption has always been, oh, well, they have less pain because there's less stress on the knee, right? That's the idea. There's less load. What's really interesting is there isn't. I mean, if they're just standing there, there's less. But once they start walking, when you lose weight, there's a subset of people who just walk faster, because they feel better, and maybe they've been exercising more. So once they walk faster and they take longer strides, they now put more stress on their knee. It's so fantastic. So they call them loaders, and so researchers were like, oh no, like what about the law of unintended consequences? What if they're going to pay for it later? They're stressing their knees even more. So this is Messier's work, who I'm seeing on this Wednesday. I have a pod, and it doesn't matter. Anyways, he's a good researcher. Still careers on this. So they load their knee more, and they followed them for 18 months to see if they paid for it later. And no, they didn't. They surprisingly kept the weight off, which is really tough. I'm surprised. Sometimes being in a study helps because there's so much like people forcing you. But so they loaded the knee more and followed them for 18 months, and no negative changes in that time.
So why then would the knee pain improve if you lose weight? Because that's a common recommendation, and it's one of the reasons a lot of people get into running is that they want to lose weight, and then the knee starts to hurt. They get an X-ray. They're told they have arthritis. They should stop running, and they're like, "Oh, bad."
Yeah, that's really. I don't really like the advice to lose weight. I get how it can be helpful for some people. If you're motivated to lose weight and something that you're driven to do and you want to for whatever reasons, fine, go ahead. But I don't think we should be telling people you have to lose weight to get out of pain. Because although it's like, this is what I mean about options. Yes, it's one option, but it's not the only one. If someone's like, listen, can't lose weight, but I'll be happy to be active and do other things, I'll be like, good, let's work together. We can do it. If you lose weight, great, if you wanted to, but you don't have to. So the rationale behind losing weight, yes, some people say it's load on the structures. I don't think so. I think it's associated with other health benefits. People might be more active, they walk more, they just feel better, they're more optimistic. And then there's the chemical sensitizing component, like an increase in adipose tissue can be related to like more inflammatory mediators. So it's a very complex neuroimmune response. Again, it's just chemicals in the joint, and those chemicals can drive sensitivity and pain. That would be the idea.
So is that why, because earlier you were talking about the structural changes related to, you call it structural or radiographic osteoarthritis, and you talk about this in the videos on the OA Optimism site. And you were saying that, this isn't a one-to-one relationship with pain, that there is a relationship there, but it's not a one-to-one relationship. And is that one of the factors? Like if you have more adipose tissue, then you will be more sensitive to the structural changes. Is that how we get this discrepancy between how much structural changes on an X-ray and how much actual pain and disability a runner might feel?
That's exactly how I view it. Yeah, it's like the structural change just is one little part of it, and then you have these other things that just make you more sensitive to what's going on. And that's why you see like weird things. This is where the psychological aspect comes in. You can't talk yourself out of having pain, but like people who catastrophize. I'm a catastrophizer. Like you just look at even though I'm an optimist, it's a bit weird. Like you just focus on like the worst things, and you just think this is horrible, or you ruminate. I'm more of a ruminator. You just keep thinking, you become hypervigilant, you get worried, you're anxious, you're fearful. These things tend to be associated with more pain as well. And so that's what's odd. I don't know if they mediate the pain via chemical changes, or if they like if you're a ruminator or you worry a lot, means you just end up not doing as much. That would be the issue. So it's again, like we said, it's complex. So yeah, I think it's more chemically driven. That's what's going on.
If you have a certain personality type, like you are, I think I could fit into this box, a bit more of a ruminator, a bit more of a worrier, a bit more of a catastrophizer, right? You're always focusing on what could go wrong. When that person has some structural changes in their knee, their body will react differently to someone who's more, let's say, generally optimistic and tends to focus on things that are positive and just kind of forget about things that they can't control and not dwell on them. And that's a way that a psychological trait might influence the actual pain that someone feels from an arthritic knee with the same amount of arthritis, like two different people, same amount, but different experience of pain. Is that one of the ways, another way in which, these two things don't marry up exactly?
Exactly. And that's exactly what we think is going on. And so what's odd is I believe in these psychosocial factors. The way I address them, the way people can address them, it's not talk therapy. That's whatever. A good explanation is helpful, but it's through physical activity. It's like you start running again or squatting again or, playing golf or tennis or something, and you're still worried and have all these traits, but it's almost like you're building a case to yourself for resiliency. So that's what I mean about reconciling biomechanics. It's like we have a biomechanical intervention here, but really maybe the target is fear, worry, anxiety, depression, catastrophizing, right? It's just they do it all together. And sure, maybe you get stronger and stiffer and good stuff like that.
I like that phrase, like you're building a case. It's like if you present to your knee credible evidence that it is still healthy enough to run, to hike, to swim, to bike, to lift weights, what happens then? If you do that, you present that case, what changes? Why does the pain improve?
Yeah, don't ask me. So one theory, goes right back to like when you take in that Gatorade, you swish it around, spit it out, and your brain predicted the response there. And that's why you had the insulin or the glucagon or the sugar change. So the brain was predicted, it anticipated, it did something before. That would be one of the ideas where somehow the brain or the nervous system just responds differently to whatever is going on at the knee. And you could have I think you can actually have specific tissue chemical changes going on there. Because the way the nervous system works, it's not just bottom up, right? It's not just sending information from the knee. Nerves can have trophic or have can inject chemicals. Inject's not there. Excrete chemicals the other direction as well. Right. It's so interesting. Like neurogenic inflammation, when you have a cut, you'll see redness around it when you're healing. That's what the nerves did. There's other things I'm not a neuroimmunologist, but there's things that are excreted down there which make you more sensitive stuff. Well, that's my favorite, like substance P. That's one of them. They didn't even try to come up with a name. They just said, it's substance P. How's that any better than stuff?
So, I mean, what would your advice to a runner be if they have been told they have? And I presume you get this in the clinic. I mean, I don't know if you want to use a specific example. Specifical? That's not a word.
Yeah.
Specific example. How do you advise runners? What do they need to think about if they've been told they have knee arthritis and maybe they've even been advised to stop running? Yeah. What are some of the things you need to think about?
I ask them what they think. Like, how have you felt? And it's what's so interesting is like, when do you feel better? When do you feel worse? And so often it's like, I feel better when I'm running. And I'm like, okay, well then we gotta run, man. Or be like, I run, but I'm a bit sore. And what do you think about that? No, I'm just sore. I'm 56. Hurts when I run a bit. How are you the next day? Back to normal. I'm like, okay, let's trust that. Right? We can't always trust the body, but we can a little bit. Right?
Well, I think I know what they think. They worry, and I would too, that in the long run it's going to get worse if they keep doing it.
Yeah. So I would, this is where you have to talk about the research. I say, well, in the long run, it doesn't seem to make it worse. And then I would also say, what do you think is going to happen? And I would say more to women, like, and just jokingly, I'm like, okay, so you're worried about getting a hip replacement or something like that. And I said, well, what would you rather have, a hip replacement or be dead? And they'd be like, what? And I said, well, you get a hip replacement, but the other thing that happens, running or hopping and skipping, these things can kind of build your running doesn't build your bone density as much. I thought it did 15 years ago. I would be like, well, running would build your bone density. And if you don't run and you have low bone density, what can happen to you? What can break my hip? And then what can happen? You can die, right? Like some people die of like hip fractures. So I thought I could catastrophize the other direction. But that's what I mean.
Scare them into running.
Exactly. Scare them into running. You got to look at it the other way. Like, what are the costs of you not running?
Yeah.
Right. That's important as well. Like, oh, okay. So there's this tiny remote chance that it increases your risk of getting a knee or hip replacement. That's really suspect. If you feel good, it's okay.
Well, I think that's the thing, is that I only in recent years have come across the research that shows, especially recreational running it might even have a protective effect against symptomatic, like painful arthritis in the knee, as far as I'm aware.
Yeah.
And I didn't know that, So if a runner doesn't know that, then they've got to be able to know that so they can weigh that up against, okay, if I quit running, what's the likelihood I'll do something else? And it's usually something easier, like walking, right? And then you're like, well, what if then you go on to develop other health problems that you could have mitigated with running, like heart disease, diabetes, obesity, like these other things that have really, like you said, like you might die from these things.
Yeah.
So you're weighing up a potentially not even a higher chance of getting a knee replacement against an almost certainly higher chance of having a serious health consequence. And that's a much, much different question.
There's that. And I don't know this research well because it's out of my sphere, but you look at like what increases your risk for mortality. And I know in men, it's often like loneliness and a sense of social isolation. And what's so great about running, especially in Canada with the running room, right? You got like people meeting to run every Sunday morning at that store. Like for a lot of runners, it's who they are. It's their social network. I would never take that away from someone. Like, you gotta keep people doing the things that they love. That's huge. Yeah. There's less of a social network and trampolining. That's the problem. That's what I miss about running. It's just me and a bunch of 20 somethings. Right?
So you used to run, right? And
I did. I just I wasn't competing anymore. I would always compete against myself because I was traveling so much. So it was hard. Like, you know what I mean? I wanted to break 20 minutes in the 5K. I always was driven by numbers.
So it wasn't because of knee arthritis. You didn't quit because you were worried about your knees.
No. I wanted to qualify for Boston, so I gave it a good year or a year and a half, and couldn't do it.
So what's your PR for the marathon?
It's 3:28.
What did you need?
Probably that year, like 3:14. It was 3:15, but it probably needed 3:13. I had done the Yasso. What was so sad, I did the Yasso 800s with an average of 3:08. I'm probably the worst, like way off. You know that predictive test where it's 10
I do. 800? But could you explain just for the listeners it? Because I've done it before. It's horrendous.
I loved it. And I did it like 2 months before. It's Bart Yasso writes for Runner's World, and he would say like a predictive test for your marathon is you do 10 800s. Right. And then I rested 2 minutes in between the 800s, but some would say you just rest the same time. So my average for those 800s was 3 minutes and 7 seconds with huge variability. And so what he says, you take your average and you turn the minutes into the hours and turns the seconds into the minutes. So my prediction would have been to run a marathon at 3:07. And I knew that was off, but I thought, oh, that's okay. I got a bit of a buffer. But I ran 3:28. Like I had a positive split of like a 1:37, 1:36 half, and then a 1:55 or something. I don't know, 1:52. It was bad.
And then you got into gymnastics.
Yeah.
And how's that going?
That's hard too. Like that's the thing. Like you're sore a lot. Like because I was trying to get really good at round up, back handspring, back tucks, and like to get better, you have to overtrain. And there's a moral here. Like so I chose to be in pain because I was trying to train 4 to 5 days a week really hard because that's the only way I could increase my skill. And I did that for like a year, and I still do it, but now I do it more I do more trampoline, I do softer stuff. So I still train 2 to 3 days a week doing it. Not so much with the COVID, but so you get, that's the thing. So like I didn't ruin myself. I'm not in pain because I trained in pain for 6 months. You can recover from stuff like that. You just have to have a choice. Like it didn't mess me up. I'm probably fitter for it and healthier for it.
Well, it reminds me of something I wanted to ask, which I forgot. Traumatic injuries. So you often see this with youngsters or people nowadays who had, let's say, torn their ACL when they were, playing hockey when they were younger. And then now they're in their 20s and 30s and they've started running, they get knee pain. And then there is some connection here. I don't want to sort of butcher it because I'm not super familiar with this, but what is the link between arthritis and some sort of major traumatic injury like an ACL?
So there is a link, but I'm not sure it's something that can be mitigated. Like, meaning it's going to happen no matter what. Mm-hmm. I think you can help yourself cope with those symptoms. That's why I think the running and strength training are important to do when you have that stuff. Yeah. Right. So I think you can mitigate it in a positive way, but I don't think the physical activity is going to change it negatively. You're going to have those joint changes regardless. Yeah. So that's what I meant. Yeah. Again, it's about coping. That's like view OA is like the physical activity and all your interventions. It's to cope with the issue that you have. Mm-hmm. You're not going to cure it, and you're not going to make those structural changes worse. You got to do the physical activity stuff and all the other healthy stuff to manage it. That's the way you want to view it.
Right.
It's the same almost with every condition. Like some of us are going to be predisposed to knee pain, right? You just manage it. You work around it. You could do it. You're not, just because your knee hurts doesn't mean you messed up. There's not something wrong with you. You can go through bouts of, you can get better, and then you can have bad days too, but keep running.
Yeah. I think what sometimes happens, I see there was a runner I used to run with in Ottawa at the running room actually, and he wouldn't run on the camber of the road. He didn't want it to be a certain way. So he would cross the road kind of thing when we were, to run on the other side. And I think that's sometimes the trouble with the sort of what you said, that the structure is the destiny. Like if you believe that it's putting more stress on that inside part where your knee, you saw the x-ray and your knee's more worn out on that part, then you're going to take actions like that. And that one on its own might not be such a big deal. But if you take, the next time something hurts, like getting out of a low chair, you're like, well, I don't sit in low chairs anymore. I'm going to sit in high, and then there's almost this sort of creeping of, it's like your functional sphere of what you can do gets smaller and smaller over time. And I think when people lose running, like you said, it's a huge one. It's a huge, like it's the social, it's psychological, it's cardiovascular fitness and health. It's like, it's all these things, and you just chunk, like a big chunk of your, you as a person is kind of gone.
No, I agree. Like I would build that sphere. That's the idea. That's what running should be doing.
You actually on your website, OA Optimism, which I will definitely plug because I'm going to start sending that to all my clients with me OA. I actually have 2 earmarked for this week that I'm going to send it to because I had heard about it, but I hadn't watched the videos. And it's not super long, and it's really easy to go through. And it's super helpful to have someone like yourself talk to clients. Do you know what I mean? Not just to clinicians, but to hear how you explain things in a very simple and succinct way. And so, I would definitely recommend that people check that out.
Well, it's nice that someone else says it too. Like I can't send people to my own website. That's I need someone. So the idea is like, if any clinicians are listening, it's good when someone else says something, especially if they're in another country, because then they're an expert for sure. Right? I wish I had, I guess I do have an accent, but if I had an Australian accent for my Canadian patients, that'd be better too. So then you get to someone tells a new concept, and then you as a clinician get to talk about it. That's it's sometimes like easier to break a new concept that way.
Yeah, it adds some validity, right? Because it's not just some, especially if you're having to contradict something that someone's been told. Sometimes a long time ago. Sometimes people have quit running 10 years ago and they're like, yeah, I'd like to run, but I can't do that because of my knee arthritis. And for me as a clinician to tackle that is daunting, right? But if I have those videos, at least it's a starting point for a conversation.
So I'm doing this panel on Wednesday with all these experts. I put experts in quotes for me, but these are legitimate PhDs studying this stuff for 30 years. I'm more of a knowledge translator and clinician. And it's on heavy resistance training for knee OA versus light resistance training. And then this general health program, which is really good too. And all the groups did better, right? Which was interesting. And so some people are upset with that because it said, oh, training really strong, that it doesn't outperform a general health program. But I'm more optimistic. I'm like, this is fantastic. Look at all these options we have. And then what's interesting is like heavy resistance. We're talking 90% of people's max for leg press and all this stuff, like super high loads here with knee OA. The big point is that group didn't get worse. They loaded the shit out of their knee, right? And really pushed it. And remember, and they were allowed to push into pain. That's part of it. There's a lot of good messaging there. So like if people, and that's open to everyone, it's ORSI, like OARSI. That's like, I forget the acronym. It has something to do with arthritis, and I don't know, it's somewhere OA. Yeah. But people can listen to that this Wednesday. There's all these researchers talking about this paper.
Cool. I will try and
I'll find you the link.
Yeah, I'll put that in the description.
I forgot about that.
Well, I think it speaks to. I was listening to a podcast with you, I think, on Physio Matters just yesterday when I was running or something.
Oh, yeah.
And it might have been a different one, but you were talking about, someone, I don't think it was with knee OA, some injury. And you were like, yeah, but you don't necessarily, you were talking about just this stuff. You were like, you could get them hiking. Do you know what I mean? You don't have to give them, I think you were talking about clams. Like you don't have to give them clamshells to strengthen their hip. If they don't want to do that, you can say, go hiking. And I was like, man, I've never done that. Like it's very predictable what you'll get from me. If you've got knee OA, it's, you'll get certain strengthening exercises and advice on titrating your running volume. And I never thought, just ask them what they like doing and get them doing something totally different. And that's their physio. Like I've never thought about that. Like that you could be quite creative, I think.
Yeah. That's why it's important for us to always question why someone gets better. The goal will be to find what's the mediator of recovery. And if it's different than what we've always thought, it probably opens us up to having different options to help people.
Yeah.
And then what I think is even just as important is if there's something that, remember in the course we start with, like, when do you have to do something specific, like to help someone? Like, are there ever times where, no, you absolutely have to build your bone density, and we know that the best way to do that is heavy strength training and hopping? Then we have to say, you definitely have to do these. You can't just go for a walk, right? Walking's great, but you need a bone density, stimulus, and you need to do it this way. So it's like good to have choices, but then when you have to be like rigid, and have fewer choices, we want to know when you have to be so rigid.
Right. Yeah.
Right? I think so. I think that's helpful.
It definitely is. Yeah. And just probably the last point, because I want to let you go, but I think this analogy is really helpful. I wonder if you could just talk the listener through it. On the website, you talk about a cup. A cup being an analogy of you as a runner with knee pain. So what's that all about?
Yeah, so it's just a simple analogy for pain, and probably inaccurate like all analogies, but it's still useful. So your pain holds all the potential stressors or all the potential contributors to pain. And when that cup overflows, that's when you get pain. So what it means is, like, you can have a bunch of shitty stuff going on in your life. You can have knee OA, you can have muscle weakness, you can overtrain sometimes, you can have poor sleep, you can be stressed out, you can ruminate and be anxious. But if your cup's big enough, you can tolerate that stuff. So if you have things in your life that are positives, that build resiliency, then you're pain-free. So treatment is either like decreasing what's in the cup or building a bigger cup. So I was asking my patients, like, what am I missing? What's in your cup here? And then our next question is like, what do you want to work on? And the easy ones, like for running, is like, well, let's work on your running volume. You're doing 4 speed sessions per week and you're not doing any easy stuff, or all of your runs are at like, close to your marathon pace. You got to slow down. So, you know what I mean? Like you got no variety in here. So most of my treatments are still really mechanical, but then people might be like, you know what? Like my work stress has been really bad these past few months. And I cope with my work stress by doing harder workouts. And those, I'm like, well, you know what? When your work stress is bad, those are kind of the weeks to like give yourself a deload week and do a plateau and cut back a bit. Or someone does the opposite where when their work stress is bad, they hardly run at all. And then 4 weeks later, they jump back into their regular training. You know what I mean? So it's always like, what's in your cup? Can we change these things here? Or are there things we can add to tolerate what's in the cup?
Well, yeah, so those would be examples, if I'm understanding correctly, of, okay, the cup's overflowing, your knee's hurting. What can we take out of the cup or modify to reduce the volume of stuff in the cup? But then you also said that you can make the cup bigger. So how might someone do that?
Yeah, so this is where I tend to be really traditional. And I would say it's adding something. So the easiest way would be what you're talking about. That would be adding hip, calf, knee exercises.
Right, okay.
You're going to cut the volume too, and then add stuff like that. It could be, this sounds odd, but like you could add, like sometimes when I'm building a runner up, I'll add warm-ups throughout the run to get more volume. So if they can tolerate 20 minutes of running, we'll do 20 minutes of running, but every 7 minutes they do a 1 to 3 minute warm-up, like skipping, hopping, karaoke. So it's like running related volume, but not actually running.
Mm-hmm.
So we're adding more would be the idea, or add like another hiking session per week. Keep your running volume the same, but add 2 like hill sessions where you walk up a really steep hill.
Mm-hmm.
And that's nice too, because you can like sell it as a performance benefiting as well. Yeah. Anytime you can check a few boxes, I think that's a good intervention. Or it could be, I always tell people, everyone says you need better sleep. And then I'm like, well, as soon as you tell someone they need better sleep, you automatically decrease their sleep quality.
Yeah.
Because now you're worried about it. So like I always say that like sheepishly. Do you think there's something you could do about your sleep, about, try to, get a little better routine?
I feel that because I get that, like, I almost feel guilty for not sleeping. Like we've been trying to buy a house last couple of weeks. We just got it done and I've been sleeping terribly. And, thinking that this might put me at risk for injury if I train too much, that doesn't really help.
So there's some research on that. Like, although everyone says it, like you kind of go look at it, like, but then I would also say, but then give yourself a break. Fine, that's in the cup, your shitty sleep for the past few weeks, but you can tolerate it. People have tolerated it for decades and centuries. So that would be building you up by saying, don't worry about it so much.
Right. One I often use is, I mean, I've been through it myself, but when people have young children, they're expected to have less sleep for a protracted period of time.
Yeah.
It comes to an end and they don't die. They don't get injured constantly, right? They cope with it.
Yeah. Yeah. No, I know sleep's a tough one. Like I almost want to say, yeah, it's okay. You can get by with this. If you can work on it, great. Go ahead. But you don't need to. And that's the point of the cup. It's like there's things in here that don't need to change.
Yeah. Yeah. You don't have to change. Everything doesn't have to be perfect.
Yeah.
Like if one thing is doing a bit better, or if you build your cup a bit bigger, like I think one for building the cup, I don't know what you think, would be like joyful stuff in your life. Like, are you doing stuff with your family and friends that you really enjoy? Or are you just spending all your time working, training, and doing the things you have to do? What are you doing that you just do for fun, I
was just going to add that. That's where I talk about like social hobbies and stuff like that, or give yourself a break. A patient of mine, she said, thank you for telling me, I probably told this joke. Thank you for giving me, the advice to write down the 3 things that I was doing really well that day. That's really helped a lot. I'm like, oh, you're welcome. In my head, I thought I never told her that, but that's the best advice ever. Everyone's getting that. And that really helped her. It's just like she's hard on herself. And I guess someone told her to like, be proud, but write down what you've done well. It wasn't me, but I got the credit and I took it.
I bet she told all her friends about you as well.
That's right.
Well, I think that's a nice note to end on. And that's certainly like not to sort of embarrass you, but your course was a real pivotal moment for me in my career. It was so helpful for clearing up a lot of the confusion I had by why people were getting better sometimes, and I didn't understand why they were getting better, and why people weren't getting better sometimes, and I didn't understand that. I had this very biomechanical kind of view of things, and sort of your course really opened up, just like you just talked about with the cup. These are all the contributing factors. These are all the ways you might be helping or not helping. And I was like, okay, right. This is a different way to look at each client and each person. And it really helped remove a lot of the confusion I'd had for the sort of 10 years up until that point. So it's a wonderful course. And you've got lots of stuff. I'm going to link up all your podcasts and stuff and the OA Optimism site. And I definitely recommend that runners especially check out your stuff because it's so helpful. It's really great.
Yeah, I got to start blogging more. And then I can get better advice on there.
Well, I mean, you've got the podcast as well with
Adam,
Physio. Yeah. Like it sometimes for runners, it can be probably a little difficult to follow, but it's still most of the time it's not so jargon filled. So I'll definitely link that as well. And your blogs are always a lot of fun.
Okay, thank you.
Thank you very much for making the time for us, Greg. I really appreciate it.
Oh, my pleasure. It's great.
Cool. Well, I will put a link in the show to the course in Edmonton if it goes ahead, and otherwise, let's hope so.
Yeah.
But otherwise,
check out that talk.
Oh yes,
check out that talk on Wednesday. If you search like Orsi, that's who's doing it. It's like out of Melbourne, but it's Wednesday at 5 or something like that.
They need to change the name. How do I spell that?
Like or and then SI.
OARSI.
Yeah.
Okay.
ARSI.
All right, I'll Google that and try and find it after we get off the phone.
Yeah, I'm not sure what it is. It's out of one of the universities there. Like, I can't remember. Something. I'll try to. I think I tweeted it out on Twitter too, so it's out there.
Okay, cool.
Okay.
I'll try and put that in the description. Thanks, Greg. I really appreciate your time.
My pleasure. Good to see you.
Take care.
Yeah.